And now it's my privilege to introduce maybe one of the most important persons in the room, because he is the editor-in-chief of the Journal of Hepatology, so the European Liver Journal, and otherwise I think Rajiv Jalan does not need any further introduction, well known and for a long time active in the field of treating and complications of liver cirrhosis, and he's talking today about tips and alpha pump for severe ascites.
Well, thank you, Heiner. Thank you, Stefan, for this very kind invitation to this viral hepatitis meeting. It's been a very wonderful afternoon where I've learned a lot. So I'm going to talk a little bit about this new device, which is called the alpha pump, for the most part of my talk, but I'll just put it into context by telling you a little bit about where we have come from. So here are my disclosures, but the most important one here is I'm a chief investigator for a European clinical trial, which is just completed enrolling. So, as we know, ascites is obviously one of the most common complications of cirrhosis, and when it occurs, then patients, this changes the outcome of the patient's survival, and nearly 50% of patients will be dead within the next 5 years. 10% of these patients per year will develop a diuretic responsive ascites will develop refractory ascites, which really means that either they develop complications of diuretics or it's not possible to mobilize this ascites. So therefore, this is a very severe situation. And what is interesting is that a large majority of these patients, about 50% of these patients, have relatively low MELD scores. So they do not have priority on most transplant waiting lists, and so therefore they're a huge problem to manage in the clinic. And so therefore, what we have at the moment available to us is paracentesis. And I just thought that I would illustrate this talk with the first patient that we implanted the pump into in order to put the story into context. So this is a young chap who has got alcoholic liver disease, who's also had hepatitis C virus infection, which was treated with interferon. He was HCV-RNA negative, but has decompensated cirrhosis manifested by diarrhea, intractable ascites requiring 2-week paracentesis. And as I said to you, this patient has a MELD score of 11. He has had one previous episode of hepatic encephalopathy, which required hospital admission, so therefore he's not really a candidate for TIPS. And so therefore, we inserted an alpha pump in 2013. He had an episode of acute kidney injury following implantation, but 12 months post-implant, he has mobilized about 100 liters of ascites. He's had no hospital admission, did not require any paracentesis, and has had an excellent quality of life leading up to his pump being explanted because there is no more ascites, and the patient is now delisted from transplantation because of spontaneous improvement in his clinical condition. So this is what he's like pre-pump, and this is what he's like when we take him off the transplant waiting list, where he's completely recompensated. So when you have a good experience with the first pump that you use, then you are more interested in taking this forward. And this is what was the impetus for us to start to develop the story about the alpha pump in patients with refractory ascites. So what do we have at the moment? So patients with refractory ascites usually have a very, very poor quality of life. And this is what we have to offer them at the moment: paracentesis, TIPS, or liver transplantation. And I just in order to set the scene, there are just a couple of important points that I wanted to make to you, because it will illustrate where we are with the alpha pump in the next slides. So the first point to make is that if you were a physician in the 1960s in the Royal Free Hospital, which is where I was, and Jeff probably started much later, but if you went to Sheila Sherlock's unit, she would say to you that if you paracentesed a patient with refractory ascites, you would kill them. What changed the paradigm was that if you gave them albumin, which is the whole basis of the Barcelona great hypothesis in the mid-70s, that infusion of albumin prevented post-paracentesis circulatory dysfunction, which is translated into improved survival in a recent meta-analysis in hepatology. So if you paracentesis somebody without volume expansion, the mortality is very high. But if you expand the plasma volume with albumin, the chances are that these patients will do well and overall better survival. And I think I'm not going to talk much about albumin except to say that it's probably one of the more important liver function, and not because it improves the oncotic pressure, but because it subserves many, many, many other non-oncotic functions, including immunomodulatory effects and endothelial function and so on and so on and so on. So very important molecule. And this is just to set the background of where we are moving to from here forward. What about TIPS? So Martin is in the audience, so I'm not going to say too much, except that TIPS is not really a panacea as we have seen it. Because if you look at any meta-analyses over a period of time, and this is paracentesis, this is just taking one of the meta-analyses, a Cochrane one. And I think what you see here is that substantial number of patients who've had a TIPS inserted will reaccumulate ascites. And here, as you can see, 60 patients out of the 130 that had TIPS implanted successfully, these are very carefully selected patients, had evidence of reaccumulation of ascites. So it's not really a panacea. What about encephalopathy? We know this, that a large proportion, about 50% of patients in these meta-analyses will develop hepatic encephalopathy after a TIPS compared with the paracentesis group, where this is significantly lower. So TIPS is not a panacea. It leads to significant improvement in ascites in the vast majority, but a large number of patients will reaccumulate ascites, and some of them will develop hepatic encephalopathy, as you can see here. What about mortality? And I think this is very important. And I just point to you first to the study by Didier Lebrec here, which really opened the face for careful selection of patients that you should do the TIPS in. And I think Martin then published this New England Journal paper subsequently showing very nicely that if you selected your patients for TIPS, you could have good outcomes for them. But if you took patients who were severely decompensated, it was unlikely that these patients would do well. But overall, I think it is fair to say that in overall analyses, TIPS does not necessarily improve the survival of patients with refractory ascites. In this meta-analysis, there are many, many, many meta-analyses in the literature. So just to summarize what I've told you so far, refractory ascites does carry a high mortality, irrespective in the non-transplant therapies, whatever therapy you use. Only 30% patients with refractory ascites in our case series are suitable for TIPS. But even in the ones that we implant TIPS into, there is some patients who will develop reaccumulation of ascites. Hepatic encephalopathy is a problem. With paracentesis, we've seen malnutrition is really a big, big problem. So therefore, and some of these patients will have a poor quality of life. So therefore, there is at least 30, 40, 50% of patients with refractory ascites in whom we do not have a treatment, and a new therapeutic approach is needed. And I think that this alpha pump may actually provide one of these new opportunities, and I just want to take the next few minutes to describe to you what it is and the data that we have so far and how we're going to move forward with it. So this is a very exciting, very clever technology. Technologically, this is a pump which is implanted under the skin, which is just like a small operation where you make a cut, put the pump in. One of the limbs of the catheter goes into the peritoneal cavity. The other limb goes into the bladder. And the idea really is that you pull the fluid from the ascitic fluid and put it into the bladder. What is interesting about this, a very clever Swiss design, which allows you to be able to monitor what this pump is doing, to set it to what volumes you want it to remove, how quickly you want to remove fluid, how do you want to put it across, and so on and so on and so on. So fully programmable, chargeable, clever pump which monitors intra-abdominal pressure, monitors the bladder pressure, before it moves fluid from one compartment to another. So of course, clever design doesn't mean clever outcomes, and this is where we are at the moment. So this is the other bit of it. That's the charger. So you apply this over the pump, and it charges the pump. But when it's doing that, it also collects information from the pump, which is relayed to the center. So from day to day, you can see as to how this pump is working, whether it's doing what it's supposed to be doing, is the pump being charged, and so on and so on and so on. So there's a charger, that's a pump, these are the catheters, there's a computer that you can use to program this pump with. So does this work? So over the period of these last 10 years or so, since this pump was first put into man, there are many, many, many clinical studies which are either being performed, in the last 5 years actually, that are being performed or have been reported. Pioneer study is the only study that is fully published. There is a study that took place in Barcelona, which is a small study which is not reported yet, an open label study. There's a European randomized clinical trial which has just completed enrolling, which some of you may have been involved with, which hopefully will describe the results by the end of this year. And I'll show you some data from that. There's a post-marketing surveillance registry. I think about over 200 patients have been treated with this device, and I'll show you some data from about 100 of them. There's a US study which is just been opened. I think there are 4 patients being treated in the US, and there is a study which is being planned by Thomas Berg, which is a randomized clinical trial of alpha pump versus TIPS, which is starting in Germany, but is going to extend to some centers in Europe. So where are the data? So this is the first piece of data from Jose Such. He was a PI for this study. And what this study showed very nicely was that this pump is able to do what is on the tin. So you can reduce the number of paracentesis procedures in these patients compared with significantly compared with a group that is getting paracentesis. So if the pump works, the chances are the patients can remain ascites-free in this particular study, followed up to 6 months. So a significant reduction in the need for paracentesis. But of course, it's an implanted pump, and when you're doing anything early on, there are complications. And in this particular study, there were significant complications in about 15% patients, which were characterized by peritoneal catheter blockage, ascites fluid leakage, bladder catheter dislocation, pump malfunction, and so on. But in most part, it is possible to replace one or the second part of the catheters in order to get these patients better. I forgot to say that these procedures can be performed under an epidural. It can be performed by interventional radiologists, or even by urologists in some places, or general surgeons. So it's a very simple operation which takes about between half an hour and 1.5 hours, depending upon how experienced you are. So what were the problems? Of course, you can move ascites, but do you make the patients better? And I think it's interesting to look at the data. There are 2 cohorts within this first pioneer study that was looked at. So as you can see, whenever you're doing a new procedure, and that's true of anything that you do in cirrhotic patients, there is a learning curve. And this is what was evidenced in the first 19 patients who had significant problems with SBP, renal dysfunction. Encephalopathy rates were not different, urinary tract infection, and systemic inflammatory response, which was significant. But in the second half of this study, so what they did was to get a group together to look to see what they were doing in the first 21 patients, had significant modifications to the protocol that they were using for implantation, and in the second cohort, there was a significantly improved outcomes, which is not very different to what's reported in the literature. So really, the first patients had many technical problems because there was no standard implant techniques, which was altered for the second cohort. Infection was common because there was no standard antibiotic prophylaxis. What they introduced was a method whereby there was an early prophylaxis for pump implantation, and then the use of norfloxacin or ciprofloxacin as secondary prophylaxis or primary prophylaxis for SBP. And many patients had increased creatinine post-implant, which was probably related to fluid, non-steroidal use, etc. So patients were being paracentised on the table, and so that without albumin infusion, and so on. So there was a sort of a critical look at this, and which is what we think led to the improvement of the outcomes of the second cohort. But of course, that was an open label study, which is very difficult to analyze, and this is what led to the European randomized study, which is again a small study, but which will include 60 patients in multiple centers. And what I'll show you is data from a small study, which is a sub-study from this randomized trial. So this is what it is. It's a multi-center, open, randomized, controlled clinical trial. Patients are randomized to either treatment with the alpha pump or standard of care with evacuation of large volume paracentesis. Many of the centers in Europe have taken part, and these are sort of all expert centers in the management of patients with ascites or advanced cirrhosis. And it's a sort of strange primary objective, which is paracentesis-free survival. And secondary endpoints are looking at complications, nutritional effects, renal effects, and so on. And I'll show you some of those data. I'm sorry, this doesn't come out very properly, but I can't show you that. So these are the results of a sub-study based at the Rowe-Free Hospital. And these are the only data I'll show you today with, to illustrate the point. So we randomized about 17 patients, out of which the data that I'll describe to you is in the first 15 of the randomized patients. And the design of this study was to look in detail at the cardiovascular parameters, to look at neurohormonal parameters, cytokines, urinary biomarkers, and so on. I'll show you some of these data, which are probably the most important ones. The first point to note is that this was highly effective. That is, over a follow-up of, in this particular report, up to 3 months, that there is a very significant improvement in the reduction in the need for paracentesis. But one of the surprising factors was, and we don't understand what the mechanism is, that although the total amount of paracentesis that the patients were requiring prior to randomization were the same, the total amount of fluid that you remove, where we can measure the amount of fluid that's pumped, was almost twice that in the paracentesis group. And there's no explanation that I can come to this, but we can discuss the hypothesis if you're interested. So, what we showed very nicely was a significant, in the red is the mid-arm muscle circumference, very significant improvement in nutritional status. And again, this is a peculiar finding, which I think is probably extremely important in the context of what we are doing. This was associated with, again, a very marked improvement in hand grip strength, which also indicates significant improvement. So what were the downsides? So this is looking at creatinine, that's looking at albumin, this is looking at renin. In the red is the alpha pump patients. What you're able to see here is that creatinine levels over a period of the first 3 months in this study, there are 2 peaks. So when you put the pump in for the first time, there is an increase in creatinine, which settles down, which we think is as a result of an inflammatory response, surgical stress, or what have you. There's no evidence of infection, which is of any significant difference. And this is associated with a significant, well, almost significant, numbers are very small. Albumin levels do not change completely, but they're lower in the patients in the pump arm compared with the controls, which is not statistically significantly different. And renin, which represents circulatory volume, is significantly higher in patients in the pump arm, suggesting that removal of all this fluid without albumin replacement is perhaps accounting for this. And in the future, we might need to replace albumin in these patients. To test this hypothesis, as you can see, the increase in creatinine correlated nicely with the increase in renin. And the reduction in albumin in the red here also correlated nicely with the increase in renin, suggesting that this regular movement of fluid from the abdomen was what was associated with this accumulation of fluid, with this increase in creatinine. Now, we did a sum to look at this a little bit further, and this is the most important slide here, that as you can see, that patients in the pump arm, so if you calculate the amount of albumin that you've removed without replacement of albumin, then you can see that the patients in the paracentesis are a positive balance, because every time you do a paracentesis, you give them albumin to replace the albumin that is lost. Whereas the pump patients are running a very significant negative balance, but despite that, they have a very significant improvement in nutrition, suggesting that pathophysiologically what we have done is a trial of pump minus albumin versus paracentesis plus albumin, and so therefore the study designs will have to change in the future. But overall, positive outcomes with the pump, but probable albumin depletion accounting for creatinine levels. So in these patients that develop AKI, if you bring them in, give them fluid, creatinine is suppressible very easily, suggesting that there is no long-term problems. What about survival? As you can see here, paradoxically, what we suggest here is very small numbers of patients, and we only looked at these data about a year ago, and this is looking at 37 patients, that the pump patients seem to be doing significantly better compared with the paracentesis group. But again, these are early data, which I don't want to dwell on too long. What about the PMSR? One more minute. So if you look at the PMSR data, does an improvement in survival translate into this? This is just 12-month survival from the literature. This is just looking at what happened to the 100 patients in the clinical trial. This is a historical data from the literature showing that certainly it is possible that there's improvement in survival with the pump, but obviously this needs to be tested, and that will be the basis of the studies that are going to be done in Germany, as I understand. So just to conclude therefore, Mr. Chairman, I think alpha pump is really an exciting new technique which requires to be studied further and to be improved in terms of how we manage it in patients. The results of the clinical data show quite nicely that it's safe to use. It is able to maintain patients without the need for large volume paracentesis. Technical issues have become very, very low. Infection risk is very low, which we've shown. I think we'll need to replace albumin, and there's a study which is just starting where we're going to replace albumin every 2 weeks. What about survival? And these data we need to wait for. There's a new trial which is being organized here in Germany, or through here in Germany by Thomas Berg, which will compare patients treated with a pump with TIPS, and I think about 230 patients will be randomized. Hopefully we'll get an answer in terms of survival. So thank you very much.
Thank you, Rajiv. We are running after time, but maybe one question. Could you identify the best candidates for this process techniques, or those for contraindication? Maybe those with kidney deteriorations are not candidates for this process?
Well, I think patients that are very sick, I think, patients that have got huge amount of comorbidity and are very sick are probably the wrong patients for the treatment. Patients who are not suitable for TIPS, such as patients with portal vein thrombosis, relatively early liver disease, they do fantastically well.
We'll take one question with rapid response. Paul, please.
Very rapidly, did serum sodium in any way predict a poor outcome or renal dysfunction when you put it in? And just if you could also rapidly comment on what urodynamics excluded patients from the study.
Okay,
Sodium change over time also.
So sodium was not a problem in the study, except that they become extremely hyper-responsive to diuretics. So they can drop their sodium very acutely if you treat them with diuretics without replacing albumin. Certainly we had one patient that became very hyponatremic in the study. So I think patients will receive albumin moving forward. And the second question was? Urodynamics is not a problem. So we did urodynamics in this study. It was not a problem. We only look for prostatic enlargement now, and which is what we've done a prostatectomy in one of the patients and then implanted a pump with good results.
Okay, thank you very much, Rajiv. Very good. I thank all the three speakers. I think it was really exciting. It's always good when you learn a lot, and I really learned a lot. Thank you very much.
Thank you.